Well, hello, everyone. Welcome back. My name is Paul Weber, and I would like to welcome you to today's teleclass, an overview of the Leapfrog Group's hand hygiene standard. Now, this teleclass actually comes from a really interesting paper of the same name that was published in the American Journal of Infection Control sometime, I think, middle of last year. It drew my attention immediately because, firstly, the word leapfrog, but it was authored by a stellar lineup of experts, including two of my favorite teleclass faculty. That is Elaine Larson and John Boyce. They've been with us for many, many years. And two of the other co-authors who compiled that AJIC article are joining us today. They are Dr. Preeti Joshi and Professor Matt Austin. Now, neither has presented a teleclass lecture in the past. They're both from Johns Hopkins University. Professor Austin is an associate professor of anesthesiology, and critical care medicine in the Johns Hopkins School of Medicine. His research focus is on performance measurement in healthcare, and he and Preeti work together in what I must say is a spectacularly named institution called the Center for Meaningful Measures. It's a really lovely name. Now, it's a treat to have them both with us to give this talk. And in a moment, I'm going to invite Professor Austin to start. But I would like to say, if you have a question for these two speakers as we go through this teleclass, you can just email that to me, paul@webertraining.com, and I will ask that question in my closing comments. So Matt, I'm going to turn the floor over to you. Matt Austin.
Paul, thanks so much, and good afternoon, maybe good evening to some of you, maybe good morning. It's a pleasure to be here, and Paul, thanks so much for inviting Preeti and I to present today on the overview of the Leapfrog Group's hand hygiene standard. So just as Paul mentioned, I'm Matt Austin. I'm at the Johns Hopkins Armstrong Institute for Patient Safety and Quality, where I'm an associate professor and as Paul made mention, do research in performance measurement in healthcare. Preeti, would you like to introduce yourself, please?
Sure. Hey, everyone. I'm Preeti Joshi. I work as a senior research data analyst at Johns Hopkins Armstrong Institute for Patient Safety and Quality. And it's my pleasure to be here and share our work that we do at Hopkins.
Great. Thanks so much, Preeti. So Preeti and I do want to disclose here at the start that we actually do receive funding from the Leapfrog Group to help support their measurement and public reporting activities, which included work to help develop their hand hygiene standards. So we do have an ongoing contract with the Leapfrog Group and just want to be sort of upfront and clear with that. As Paul made mention, we did publish a recent article on this topic. So if you are deeply interested in it and want to read more or refer back to some of this information later, the American Journal of Infection Control is where it was published. And we were lucky enough to have some of our expert panelists, including Drs. Larson and Boyce, who joined us in the authorship of that article. So on today's session, we really have three primary objectives that we're hoping to cover with you. We're going to talk a little bit about the 5 domains that make up the Leapfrog hand hygiene standard and the evidence that supports each of those domains. We're going to talk a little bit about how Leapfrog developed, tested, and has refined its standard through both expert consultation as well as pilot testing with hospitals. And we're going to share some of the data showing U.S. hospital adherence to the hand hygiene standard as well. Before we go too far, I think it's important to sort of ground everyone in the US healthcare system. And so we're going to talk a little bit about who is the Leapfrog Group. I'll do that on a future slide, but I think it's important to sort of frame why an organization like the Leapfrog Group might be needed or would be founded in the United States. So in the United States healthcare system, we still operate primarily an employment-based insurance system. So the latest estimates are that 55% of Americans have their health insurance either through their employer or the employer of a loved one. 36% of Americans have their health insurance through the government. That would include Medicare and Medicaid. 9% of Americans direct purchase their health insurance. And I think it's important to note that 8 to 9% of Americans actually don't have health insurance. So here in the United States, we don't have necessarily a guaranteed right to health insurance. And so there still is a portion of the population that doesn't have access to it. But what's important to take away from this is the idea that in the United States, we still operate in a system where most individuals get their health insurance through an employer. And one estimate is that US employers spend anywhere between $500 and $950 billion each year on health benefits for their employees and their families. So it's a significant amount of money that employers are spending on healthcare, and a significant portion of the US healthcare system is actually paid for by employers. So these employers were sort of caught off guard in 1999 when the Institute of Medicine issued its To Err is Human report, which found that somewhere between 44,000 and 98,000 Americans die in US hospitals each year due to preventable medical mistakes. And I think really what frustrated these employers was they were surprised by the lack of transparency, right? There was no sort of information about the quality and safety of care that was available to them as employers and ones paying for a lot of the healthcare. And so that's really what the origins of the Leapfrog Group were. It was employers coming together to flex their collective purchasing leverage. So companies like General Motors, GE, Boeing, FedEx, Marriott came together and said, we really want to drive improvements in the quality and safety of the US healthcare system. So the Leapfrog Group was founded in 2000, so we're now at 26 years. It's a 501c3 nonprofit organization that's based out of Washington, D.C. And its mission is to make giant leaps forward in the safety, quality, and affordability of healthcare in the United States by promoting transparency through both data collection and public reporting. And so, as I mentioned to Paul before we jumped on today's session, Leapfrog is really grounded in this idea of transparency. How do we make information available to those who are using the healthcare system, patients, and those who are paying for the healthcare system, employers, about the quality and safety of the healthcare that's being delivered in the US healthcare system? So its primary mechanism for collecting information from hospitals is the Leapfrog Hospital Survey. The Leapfrog Hospital Survey is an annual voluntary survey that over 2,000 US hospitals complete each year. The survey covers a wide breadth of quality and safety domains, information on infection prevention, medication safety, maternity care, hand hygiene, surgical outcomes. And results from that survey are publicly reported, and they're also used in a variety of other ways, including the hospital safety grades, which we'll talk about a little later on in the presentation. And so the Leapfrog Hospital Survey is really the primary mechanism that Leapfrog uses to drive that goal of transparency. So it's collecting information from hospital about quality and safety and making that information publicly available. So with that, I'm going to turn it over to Preeti to walk us through the next part.
Thank you, Matt. That really sets the stage nicely. So before we dive into Leapfrog's hand hygiene standard and how it was developed and why it was developed, I want to take a step back and talk about why hand hygiene matters and why this is such a critical issue in patient safety. Now, as we all know that healthcare-associated infections are a major cause of harm in US hospitals, approximately 700,000 patients acquire hospital-acquired infections annually, and among them, 1 in 9 patients die. This infection costs the US healthcare system around $7 to $15 billion each year. And these infections are preventable. Hand hygiene has shown to be the most effective way to prevent infection spread. It can prevent up to 50% of healthcare-associated infection. Despite its simplicity, this method is underutilized. The average hand washing compliance is only 50% across hospitals. So now let's talk about why Leapfrog developed a new hand hygiene standard. Early versions of Leapfrog Hospital Survey used the National Quality Forum's Safe Practice 19 to report on hospital adherence to hand hygiene practices that was established by CDC. In 2018 survey, over 80% of hospitals reported full adherence to Safe Practice number 19, yet we noticed that hospital-acquired infections remained really high. That is why Leapfrog identified a need for a more robust and comprehensive standard. Now let's talk about how this standard was developed. Leapfrog assembled a national expert panel, including physicians, nurses, public health professionals, and a federal agency representative. This panel met 2 to 3 times per year during development of the standard. The standard is based on WHO Hand Hygiene Self-Assessment Framework, and I'm going to talk about how tightly it is aligned with this framework in the next slide. But Leapfrog did adapted the WHO framework for US hospitals by removing topics that are already established in the US healthcare system. For example, continuous access to clean running water. This standard is made up of 5 domains that really ask questions like, are hospital staff properly trained? Do hospital have the right infrastructure in place? Are they actively monitoring hand hygiene compliance? Are they providing feedback to the staff? And finally, are they providing a culture that supports and sustains hand hygiene? So as you can see on the slide, Leapfrog's standard tightly align with the WHO's self-assessment framework. One key difference is that Leapfrog separates monitoring and feedback into distinct domains, placing more emphasis on both measurement and accountability. Overall, Leapfrog builds on the WHO framework but adapts it to be more actionable and measurable for US hospitals. Now, how does Leapfrog identify expert panelists? And this is important. The Leapfrog Group has 13 national expert panels that help guide the measurement and public reporting work on the Leapfrog Hospital Survey. These panelists are typically individuals who have published research on that healthcare quality topic of interest and are seen nationally as leaders in their field. They do not get paid for their service on the expert panel. They volunteer their time as part of the mission. These panelists complete a conflict of interest form, and every expert panel call begins with a round of disclosure. We are extremely lucky to have so many bright, talented, and committed folk volunteer their time to help us with this work. Before diving deeper into what Leapfrog's hand hygiene standard looked like, I want to highlight the expert panel that guided the development of the standard. This panel includes nationally and internationally recognized leaders in infection prevention and patient safety. From institutions like the CDC, University of Chicago, Virginia Commonwealth University, Columbia University, and University of Maryland. Current panelists include experts like John Boyce, Emily Landon, and Gonzalo Bierman, who have extensive experience in infection prevention and hospital epidemiology. We have also benefited from contributions of former panelists, including leaders from the CDC and academic nursing and medical institution. Now let's dive deep into each domain. The first domain focuses on ensuring that all staff are properly trained in hand hygiene. They must complete both initial and annual training on hand hygiene. Staff must physically demonstrate proper technique using both soap and water and alcohol based sanitizer. Training includes key elements like timing, technique, glove use, duration, and how compliance is monitored. And there is strong evidence showing that structured training and education significantly improve hand hygiene compliance. The second domain focuses on infrastructure, making sure the environment supports hand hygiene. First, sanitizer and sinks must be easily accessible, both at room entrance and inside patient care areas. Second, hospitals are required to routinely audit dispenser to ensure they are stocked and functioning properly. Third, and this is important, the standard ensure that each dispenser delivers enough sanitizer, at least 1 milliliter, so hands are fully covered and the product has enough time to dry and to be effective. Studies have shown that when infrastructure is accessible and functional, and when enough sanitizer is used, compliance improves and decreases. So this domain ensures that hand hygiene is not just expected, but easy to do and effective every time. Then comes third domain on monitoring, because you cannot improve hand hygiene without measuring it. So, in this domain, hospitals are required to collect hand hygiene data on at least 100 opportunities per month per unit care, per patient care unit, sorry. This can be done using direct observation or electronic monitoring system. In addition, trained observers or coaches are used to provide performance feedback to staff. Studies show that hand hygiene monitoring, especially electronic systems, when combined with direct observation and active feedback, significantly improve hand hygiene compliance and can reduce healthcare associated infection. So, this domain ensures that hand hygiene performance is consistently measured, tracked, and improved over time. Once hospitals are measuring performance, the next step is using that data to drive improvement, and that's where feedback comes in. First, hospitals provide monthly feedback to individuals and use that data to develop unit level action plans. Second, performance is regularly reported to senior leadership and the hospital board, and leaders are held accountable through performance evaluation. Research show that timely feedback, especially when paired with accountability, leads to meaningful and sustained improvement in hand hygiene performance. So this domain ensures that monitoring data is not just collected, but actively used to drive change at both the frontline and leadership levels. Finally, the fifth domain focuses on culture, because sustainable improvement requires more than system and processes. This domain encourages patients and visitors to actively remind staff about hand hygiene. This helps create a shared responsibility for safety. It also requires senior leaders such as the CEO, CMO, and CNO to demonstrate formal commitment to hand hygiene improvement. Research showed that both patient involvement and sustained leadership commitment play a critical role in improving and maintaining hand hygiene compliance. So, this domain ensures that hand hygiene becomes part of the organization's culture, not just a task, but a shared priority. Now that we have covered the 5 domains, let's talk about how hospitals actually achieve the standard. Leapfrog assigns hospital 4 performance category based on their performance, ranging from limited achievement, the lowest possible category, to achieve the standard, the highest possible category. To meet any domain, Leapfrog must answer yes to all the questions within that domain. Importantly, monitoring and feedback are required. Hospitals cannot achieve the standard without meeting them. If a hospital collects 200 observations per unit per month, they must meet monitoring and feedback, plus any 2 of the remaining 3 domains. If a hospital collects 100 observations per unit per month, they must meet monitoring and feedback plus all 3 remaining domains. So, essentially, collecting data on more observation opportunities give hospitals some flexibility. Now let's talk about testing of the standard. Since implementation, the hand hygiene since now let's talk about the testing of the standard. I'm sorry. The standard was pilot tested in 2019 with around 1,700 hospitals. Survey was completed through cross-functional collaboration, including quality, infection prevention, patient safety, and IT departments. It's noteworthy that pilot responses were not scored or publicly reported. The pilot responses were used to get feedback, to get the feedback and improve the survey question and improve the domain structure of the standard. The full implementation was done in 2020. The scoring and public reporting began from 2020. Since implementation, the hand hygiene standard was continued to evolve based on feedback and real-world use. First in 2020, following pilot testing, Leapfrog's expert panel recommended separating the monitoring and feedback domains. This change simplified the structure of the survey and highlighted the distinct roles of measurement and action in improving hand hygiene. Also in 2020, Leapfrog introduced a culture domain to capture the importance of hospital's safety culture. In 2021, Leapfrog clarified which units are included in the standard by defining patient care units. This include inpatient unit, outpatient pre- and post-operative units, observation units, and emergency units, while excluding areas without direct bedside care, such as operating rooms, pathology, and radiology departments. Finally, in 2022, based on feedback about feasibility, Leapfrog introduced an alternative pathway to achieve the standard. While the original requirement was 200 observations per unit per month, hospitals can now meet the standard with 100 observations if they satisfy all other domains. Overall, this refinements made the standard more practical, clearer, and easier for hospitals to implement. Before we talk about the results over time, Let's talk about ensuring the self-reported data submitted by hospitals are accurate. To ensure the reliability of the data, Leapfrog uses a multi-step validation process. As a first step, hospitals provide an affirmation of accuracy when submitting their data. Next step is the submission tool includes built-in warning to flag potential error or inconsistencies. Third, Leapfrog conducts monthly data verification to review submitted data. Fourth, hospitals may be asked to provide documentation to support their responses. And finally, Leapfrog also performs on-site data verification for an additional layer of validation. So this is not just self-reported data. It is actively reviewed and validated through multiple checks. This layered approach helps ensure the accuracy, credibility, and trustworthiness of the data that is being publicly reported. Now let's review the results over time. We have 6 years worth of data on the screen. Since implementation in 2020, we have seen substantial improvements in hospitals' performance across all domains. Most notably, hospitals fully achieving the standard increased from just 11% in 2020 to 82% in 2025. We also see consistent increases across each domain, particularly monitoring and feedback domains, which started lower but showed significant improvement over time. This suggests that hospitals are not only adapting the standard, but strengthening their system for measurement, feedback, and accountability. Over the next 5 slides, we'll walk through a few charts that highlight hospital performance over time for each domain. These are based on selected question level measures, so they provide a snapshot rather than a complete view of all the questions. This slide shows trend over time in hospitals requiring staff to physically demonstrate proper hand hygiene. As you can see, there is a steady increase from about 58% in 2020 to over 86% by 2025. This indicates that more hospitals are moving beyond just training and ensuring staff can actually demonstrate proper hand hygiene technique. Then comes infrastructure domain. And the chart on the screen show the percentage of hospitals with processes in place to ensure hand hygiene supplies are available and operational. We see an increase from about 81% from beginning to over 95% by 2025. Importantly, performance was already relatively high at baseline, but still showed meaningful improvement. The next chart shows the percentage of hospitals conducting audits to ensure that the proper amount of hand sanitizer is delivered with each use. And we see substantial increase from 60% to 92% over the period of time. This is an important improvement because it reflects attention not just to availability, but to whether the sanitizer is actually effective. Next is monitoring domain. And the slide highlights trend in how hospitals are monitoring hand hygiene compliance using electronic system and human observer. We see that the use of electronic monitoring has increased from 5% in 2020 to just over 10% in 2025. It is noteworthy that the use of electronic monitoring has doubled over time, but has still remained low. This limited adoption is likely due to cost and implementation challenges. In contrast, the use of trained observers or coaches is very high, rising from about 59% in 2020 to over 90% by 2025. So while electronic monitoring is growing slowly, most hospitals rely heavily on direct observation to monitor hand hygiene compliance. This chart shows the percentage of hospitals providing hand hygiene performance data to leadership and holding leaders accountable. And we see clear increase from about 50% from beginning to 90% in 2025. It suggests that more hospitals are not only collecting data, but actively using it to drive performance at the leadership level. And the last slide highlights trend in culture domain, specifically patient engagement and leadership commitment. We see that hospitals invite patients and visitors to remind staff about hand hygiene was already very high, around 93% in 2020, and increased slightly to about 98%. Similarly, leadership commitment has remained consistently high, increasing from 93% to over 98%. So unlike some of the other domains, culture started strong and has remained consistently high over time. And with that, I will turn it over to Matt.
Preeti, thanks so much. So I want to just walk everyone through a little bit what the reported results look like for the hand hygiene standard. So as I mentioned earlier, the Leapfrog Group is really grounded in this idea of transparency and how do we make information available to those who use the healthcare system, consumers and patients, and those that are paying for the healthcare system, employers. And so Leapfrog has a public reporting website. If you go to leapfroggroup.org, in the upper left-hand corner, the upper right-hand corner is a link to the public reporting website. You can search by facility name, you can search by location. There's also opportunities to look at some specific procedures and types of care as well. So wanted to provide a couple of examples. As Preeti outlined earlier, Leapfrog puts hospitals into 4 performance categories. Achieve the standard is the highest performance category. Limited achievement is the bottom performance category. And Leapfrog uses a cell phone bar methodology to report out its results. So hospitals that achieve the standard are reflected as 4 filled cell phone bars. And as you'll see here in a second, limited achievement will be 1 cell phone bar. And so in addition to providing some of the information about hand washing, which is, I think, sort of a term that might resonate better with consumers than hand hygiene, Leapfrog does provide the detail about the 5 domains and whether the hospital met each of those 5 domains. Here's an example of a hospital that it was limited achievement. As I explained, they have 1 cell phone bar, and they actually did not meet any of the 5 domains. So Leapfrog's information that it collects through the Leapfrog Hospital Survey gets used in a variety of ways, and the hand hygiene standard is no different. As we've already discussed and just covered, the information that is captured through the hand hygiene standard is publicly reported. Leapfrog does publicly report out safety and quality performance to help promote transparency and accountability in the US healthcare system. Leapfrog has a separate ratings program, which is called the Hospital Safety Grade, which is a letter grade that gets assigned to hospitals based on how they're doing in patient safety. That's an A, B, C, D, or F grade. And the hand hygiene standard is used as part of that calculation. Leapfrog annually issues a top hospitals list based on how hospitals do on the standards included in the Leapfrog Hospital Survey. And so they received the Leapfrog Top Hospital Award. And then Leapfrog operates its own value-based purchasing program, helping employers, health plans, and others identify high-value hospitals in their markets. So we think this standard is important for a number of reasons. First, the standard is actually, I think, groundbreaking in a few ways. One is it really leans into one of the domains focuses on infrastructure readiness. I think there was a strong thread from the expert panel that in order to have consistent hand hygiene compliance and adherence, one really needs to make sure that the infrastructure is in place and supports regular hand hygiene, right? So it's ensuring that, that there's dispensers in convenient locations, that when you put your hand underneath one of the automated dispensers, that some alcohol-based hand rub comes out. I think we've all experienced putting our hand under one and nothing is in there. So we need to make sure that there's actually product in the dispensers. So how do we help support healthcare workers in actually consistently carrying out hand hygiene? Second way I think that the standard is really sort of cutting edge or novel is it does set a minimum monitoring volume. I think this is an area where continued research needs to be done, but with the Leapfrog hand hygiene standard, there was a willingness to put a stake in the ground and say, this is the number that we expect hospitals to be collecting each month. And then the third piece that I think is really novel is this idea of leadership accountability. How do we hold leadership accountable for hand hygiene? How do we tie it to their performance reviews and make sure that they buy into a robust hand hygiene program for their hospital? As I think Preeti did a nice job of outlining, the standard goes beyond just simple compliance. It's not just monitoring. Feedback is important. Education is important. Infrastructure is important. And culture, I think, is incredibly important. And hopefully this provides hospitals with sort of a how-to roadmap, right? And so we'll talk here on a future slide about, all this information is publicly available. So hospitals and those outside of the United States, we would urge you and welcome you to tap into those resources. So we do have a few future directions that we're heading in regarding to the standard. As Preeti mentioned, part of the standard does look at electronic monitoring systems. I think we continue to assess and evaluate where those fall into the bigger picture of a national hand hygiene standard. We've had conversations with the expert panel about potentially expanding to other infection prevention practices. And we continue to refine the standard based on evidence, based on feedback. So where the standard is today may not be where the standard is in the future. We hope to continue to evolve it over time. So hopefully some of the key takeaways for you all today is that hand hygiene is critical for patient safety. I don't think we need to really sell you all on that, the importance of that. But I do think the Leapfrog standard does offer a comprehensive and evidence-based approach to thinking about hand hygiene and how you might measure that. We've touched on the 5 domains that make up the standards. And as Preeti showed with the data, we've actually seen pretty good improvements nationally on the standard over the last 6 years. So some of the frequently asked questions we get is, where can you find information about the Leapfrog Hospital Survey, information about the hand hygiene standard? Please visit the Leapfrog Group's website. We probably should have noted that here, but that's leapfroggroup.org. The survey, all of the materials are publicly available. So in the spirit of transparency, everything Leapfrog does is made available in a public way. We have gotten questions about whether they can submit feedback for improvements to Leapfrog's hand hygiene standard. Leapfrog does hold a 30-day public comment period every year, typically kicks off in mid-November. And so there is the opportunity to submit comments and suggestions. And what we do with all that information is we actually review that with the national expert panel, and we use that to inform updates and improvements in the next year's survey. So with that, we'll just say a big thank you. Thank you to all of you for attending today, hearing about the standard. And Paul, thank you for the invitation to join and to share the work we've been doing. Thanks so much.
Matt, thank you. And Preeti, thank you very much. I'm going to move one more slide because you very generously provided your email addresses. Now, you may come to regret that, but it's very generous of you to do that so that our attendees can contact you directly. I presume that that's acceptable, being as how you put the addresses there.
Absolutely. We would welcome hearing from folks and engaging with folks. So yes,
Right.
Please reach out.
So I just have some questions and comments. We didn't receive any questions from the audience. Direct observation versus electronic monitoring. Now, this has been the question for years. As long as we've been talking about hand hygiene and improving hand hygiene, it's been how can we get it out of direct observation? Because if there's somebody there standing there watching, obviously the compliance goes up. And I've had this envision every time I go for a walk with my iPhone, measuring my steps, and I go for an extra long walk so I can get those steps up. I think, my goodness, wouldn't it be wonderful if everyone carried their iPhone in their pocket, and every time they cleaned their hands appropriately, they got a reward or an acknowledgement, and every time that they missed something, it was noted, and just something like that happens automatically. But how is it that electronic monitoring, I mean, it's nice to think you could use it because it would give you some hard data, but can it compete with direct observation? Must it always be double? And how can it be better?
Yeah, so I'll jump in first, and Preeti, I would welcome you to share your thoughts as well. I think this is an issue that the expert panel has struggled with, and the way Leapfrog's standard is currently structured, hospitals have the opportunity to indicate that they are using electronic compliance monitoring systems for their observations, or they can indicate that they're doing them with humans. I think you're right, Paul, there are some trade-offs. I think in terms of the advantage of the electronic compliance monitoring systems, it has the distinct advantage of its sort of ongoing, all the time. It's the amount of data you can collect is exponential compared to human observers. It also has the advantage, as you noted, of the Hawthorne effect, and I think it sort of disappears more quickly if it's just sort of part of your everyday environment. The other thing that Leapfrog really has noted too is sort of the ethical concerns with a human observer watching a healthcare worker not perform hand hygiene and letting that go by as a failure. So if with an electronic compliance monitoring system, you sort of take that ethical dilemma out. But the big disadvantage is the cost, right? These systems are not inexpensive. Leapfrog is hoping that as it continues to gently push in that direction, that it creates innovation, it creates a demand, it creates hopefully lower prices of adoption. My understanding is that there's some badge-based systems that are really slick that they can note when a healthcare worker has come into the room, and if after 15 seconds they haven't performed hand hygiene, something starts buzzing on your badge to sort of remind you that you need to go do hand hygiene, right? So it can not only be monitoring, but it can also be a reminder system. So I think just we need more information, we need more evidence, and I think we need to sort of evolve the field as well.
Preeti, did you have any comments?
Matt has covered everything, and I echo what he said. I just want to add that, as Matt said, that electronic compliance monitoring has advantages, and it can prevent the Hawthorne effect that direct observation has, and it can be helpful in monitoring. It can remind healthcare workers to do the hand hygiene if they forget. And I like the idea that you shared, Paul, to get the instant reward, just like we see in our Apple Watches when we go outside for a walk, and when we come home and we get notification that, oh, you have closed all 3 rings, right? And that gives us like a sense of achievement. So that would be great if the electronic compliance monitoring are able to do. So
it would be nice.
Yeah.
Yeah, if you could accumulate hand hygiene points throughout the day.
Right.
Exactly. Of course,
right.
Technology always has a cost, as you said. It's a matter of can we implement it versus how much is it going to cost to implement it. So if it gets down to something that everyone is wearing or everyone is carrying anyway, I think that really brings it down home. Now, you in your slides, you had some hard data that measured safety culture. How on earth unless I'm misunderstanding what you're defining as safety culture, how did you get hard numbers for something as liquid as safety culture?
So Leapfrog is looking really at 2 elements when we talk about culture. One is, does the hospital encourage patients, visitors, family members to speak up, to remind healthcare workers to clean their hands, right? So do you empower patients to and their loved ones to remind staff about hand hygiene? So that's one element. The other element of culture is related to senior leaders in the organization, the CEO, the chief medical officer, the chief nursing officer. Have they offered a formal commitment to hand hygiene improvement? So have they, sent out an email to the hospital? Have they mentioned it in a, sort of town hall setting that, hand hygiene is important and we're going to continue to work to improve upon it? So there's a separate element within the Leapfrog Hospital survey around patient safety culture measurement. So that is captured in another part of the survey where hospitals are asked to actually do a biannual survey of their employees around culture of safety. But that's not specifically the part of this culture part. This is really about, leadership and empowering patients.
My understanding of culture is it usually starts with the influencers at the bottom and works its way up, as opposed to starting at the top with an idea and a concept and being pushed down. So it's invariably difficult, nigh impossible to quantify.
Yeah, I mean, I think it's important, though, for senior leaders to message what the values of the organization are, right? That
absolutely
hand hygiene is not a nice to have; it's a must do, and this is what we need to do to keep our patients safe.
You think that would be baseline? Let me ask: the public reporting, does that have a component of sort of name and shame to it?
So Leapfrog hospital survey is a voluntary survey, right? So hospitals can choose to complete it or they can choose not to complete it. If they are asked to complete a survey by an employer or an employer group and they choose not to, Leapfrog does reflect them on the public website as declined to report.
Okay.
Which we have heard feedback through the years from some hospitals that language is negative. which is sort of the intent, right, is to do a little bit of shaming, to say you were asked to provide information and you chose not to be transparent with that. So, with the 4 performance categories, it's not really to shame a hospital. It's really to inform that hospitals are at different stages of implementation of the standard and to be transparent with where that hospital is.
Right. Well, this has been very interesting. I'm so very glad we did this, and I'm looking forward to doing an update on it in the future to see the results. I'll just move on. We have, of course, a whole year's worth of teleclasses booked, but in the next few weeks, Julie Storr from the UK will be presenting a lecture that I particularly like. Is infection prevention and control guidance fit for people? The case for compassionate, person-centered infection prevention and control. Now, during COVID, we saw how many things were not compassionate and were not person-centered, and the result of that was a great washout of healthcare workers. So that's a very interesting topic. Our Australasian series on the 22nd with Kathy Dempsey presenting infection prevention and control response and escalation framework, evaluation and application beyond a pandemic. And then the second International Federation of Infection Control teleclass of this year, the new WHO and UNICEF global guidelines on hand hygiene in group settings. And that will be presented on the 28th. Thank you to IFIC for all their support this year. And lastly, thanks to our patron sponsors, Diversey, Envirox, and Gamma for their financial support. We receive small bits of money from all sorts of different places, and these guys certainly help us quite a bit. As I've mentioned, I think many times, teleclass education does not make money, never has, probably never will. But it's a very satisfying thing, and I thank these organizations for helping us do that. So thank you to all of you for joining us today. And to Preeti and Matt, thank you again very much. This was a very interesting talk and a good topic, and we're going to do it again. I'm looking forward to hearing more about this. So until we meet again, everyone, thank you for now, and goodbye.